This episode of the Curbsiders is sponsored by the American College of Physicians. Post-training docs save $100 on their first-year membership dues through June 30th. Visit acponline.org/member and use the code ACPDiscount. The Curbsiders are now partnering with VCU Health Continuing Education to offer CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
So, we're back. This is another COVID Cakes episode. Paul and Stuart are not here, unfortunately, but we do have a great team, and we're going to introduce them now, and they're going to tell you about what they're going to be talking about. So first up, the great Rahul Ganatra. Rahul, how are you doing?
I'm doing great. How are you, Matt?
I couldn't be more fantastic. This is what I love to do with my evenings, talk about COVID. So tell the audience, Rahul, what are you going to be telling them about tonight?
Tonight, we're going to be talking about the ACCT-1 trial, the preliminary report that's been making a lot of news, just published in the New England Journal of Medicine. And we're also going to talk about a trial published in The Lancet looking at the use of a triple combination therapy on reduction to the time of negative nasopharyngeal swab. All
right. Also with us is Dr. Emmy Okamoto. Emmy, welcome back.
Thanks. Yeah, good to be here. So I am going to refresh everyone on what RT-PCR is and how much we should be trusting those results, particularly when they come back negative.
Okay. And with us, as always tonight, is the wonderful Sarah Phoebe Roberts. Sarah, good to have you here, as always.
Thanks, Matt. So I don't know if everybody has been listening to the news, but I am here to set the record straight about what the CDC has or has not said about fomites and COVID transmission.
All right. So without further ado, let's get on with it. We wanted to start it off a little bit light. And Sarah, I actually want to start with you because I want to talk a little bit about fomites. I understand that there's some misinformation out there. And then so you tell me first what you want to talk about. Then I have some follow-up questions for you.
Absolutely. So I'm not even sure if misinformation is the right word. I think it's more of sort of a negative space, a lack of information that's been spun into something else, which is basically the CDC, as we know, has the page on their website where they talk about kind of the basics of coronavirus, what we do and don't know, and how the disease is transmitted. And so previously, the issue of surfaces, also known as fomites, had its own dedicated section that basically recommended wiping down surfaces and being cautious about, touching an elevator button and then putting your whole hand in your mouth or whatever. So what happened is that recently the CDC just kind of reorganized that page. They didn't remove any substantial information about surfaces because, frankly, there wasn't a lot of substantial information. Everything is very new. What they did was they moved the brief mention of fomites into a section about, titled more or less, "The disease does not spread easily in these ways." So again, there was no new evidence, and they went on the record saying, we did not make this change based on any emerging evidence that fomites are no longer a risk, but more so we were just trying to reorganize things. And, in essence, surfaces are not necessarily the most dangerous mode of transmission for this disease, which we've kind of known from the start that that's not the primary way this disease spreads. So, however, this was picked up by some major media outlets and framed as CDC says surfaces are no longer like a dangerous mode of transport for the disease. But really, nothing's changed. Everything is exactly the same.
Okay. So from like the first ever COVID episode we did where most, on most surfaces, it's gone in 24 hours, but on like the plastic or metal surfaces,
Stainless
maybe
steel.
up to a couple days.
Right, but it's still the same case of most of the viral load is diminished. The half-life is short. So even within like 6 hours or something, more than 50% of the viral load is gone. And I've seen other pieces that have commented on just that it would be fairly challenging. I think there was a New York Times article I recommended a couple weeks ago that and again, it's not to recommend people stop washing hands or stop disinfecting surfaces, but more so just it's not the primary way that this disease is spread. Right. And so there's also a lot of other mitigating factors about how much viral inoculum is present and sort of what you're doing with your hand. And, there's like how recently it was placed there. And so
can I interrupt you then and ask you?
Of course.
So were you doing anything weird with your groceries, or are you just like, you buy a bag of chips and you're just like right in there day one,
yes.
hour one?
Like Kirby, I just insert the entire bag in my mouth. I don't even open it. It's frowned upon in my household. Anyway, so it never occurred to me to Clorox groceries until a friend of mine in New York City, who has been very active in PPE drives, recommended it. And so, yes, I began the process of taking a Clorox spray and a microfiber cloth and wiping down my oranges and my milk. And
so we'll have to link to this. There's a JAMA article. I want to see what Emmy and Rahul are doing, but there's a JAMA article. They weren't really recommending that people are like Clorox wiping stuff. They're like, because of like what we talked about, within the first 24 hours, most of it's gone. They're saying just put stuff away. You can unbox stuff if it can be like put in a fresh container. Rahul, what are you doing with your groceries? Like, what about produce?
Well, yeah. I mean, for dry goods, we would basically put them aside and kind of not touch them for 24 hours and then feel very good that, any virus particles that had made it onto those things were probably dead. And we just try to remind each other to wash our hands and, be smart about that.
Yeah.
I won't lie. There was a period early on when we were like aggressively scrubbing bananas, like fools. But I'm happy to report that we are no longer doing that in our household.
Yeah. Emmy, do you eat produce? And if so, what are you doing with it?
Yes. Same for me. My mom watched a YouTube video from a doctor who's like, wash your clementines like you wash your hands. So she's like 20 seconds, for the clementine.
I think the JAMA paper says you can just rinse them with water. And then, I think my wife uses some sort of a veggie scrub on the produce, but otherwise we're just kind of either unboxing stuff or just letting it sit for 24 hours or more before we touch it. So anyway, fomites, the bottom line is fomites aren't the biggest problem with this whole thing, but wash your hands and be thoughtful. Emmy, was there something about rats?
Yeah. Did you guys see a CDC warning that rats may become more aggressive?
I did not.
COVID era?
I do not like that at all. That's
very
alarming.
Clear. As someone who lived in New York, that's a hard one.
So it's new, particularly New York, because the restaurants aren't open. So where do most of the rats get their food is from the restaurant and whatnot. So with the restaurant closures, expect hungry rats at your doorstep.
We're going to have to apologize to our producer, Deb, who wanted this to be a good news section. So I believe rats being more aggressive is not good news, Emmy, but we'll let it slide. ACP is the professional home for internists and a fierce advocate for the internal medicine profession and for patients. ACP offers so many great resources. MixApp is fun and it will help you crush your boards. They have online POCUS learning activities where you can claim CME credit. Plus, once things start up again, their live POCUS courses are fantastic. More recently, I've been using the ACP Physician's Guide for COVID-19 as kind of my home base for keeping up with everything going on during the pandemic. It includes a clinical overview of infection control, patient care guidance, and information related to billing and coding to help you navigate telehealth. There's also many online modules that offer free CME for members. These are just a few of the many reasons ACP members are proud to be internists and to be part of the college. For a limited time, post-training docs save $100 on their first-year membership dues through June 30th. Visit acponline.org/member and use the code ACPDiscount. And I think we're going to move on to talking about the ACT-1 trial, which was like the big news. As big a news as the grocery stuff is, this was the big news. Rahul, so I'll give you some of the abstract version, and then you tell us how you read this trial. So this was remdesivir. This was the big Dr. Fauci trial. Actually, he wasn't the lead investigator, but this is the NIH trial, and it was a randomized, placebo-controlled, double-blind trial, IV remdesivir versus placebo, and there was over 1,000 patients in it, and they read this as a positive trial that the recovery time was significantly shorter in patients receiving remdesivir, and there was a trend towards a mortality benefit, but it was not statistically significant. The confidence interval crosses 1. So, Rahul, how do you read this trial? Is there anything key to point out to the audience?
Yes. I mean, this is probably one of the most talked about trials in recent memory for me. I mean, I can't remember anything before COVID-19 that kind of got this much media attention, and particularly around like the details of the design. I mean, it is kind of thrilling to see all the, nitty-gritty details of the methods come under such public scrutiny. But, before this paper was published, there was a lot of attention paid to the reality that the primary outcome was changed in this trial. And that's something that happens from time to time in randomized controlled trials. And it can be a problem. Okay, it can be a problem if you think that makes it more likely that a positive result is explained by the authors having done that. Okay, and there was a lot of great reporting in Stat News that we touched on briefly in our last episode, where they actually got a lot of detail. They spoke to a lot of people at the NIH about that decision. And after reading the paper, I and many others feel relatively reassured that changing the primary outcome was kind of a non-issue in this study. What they basically did was they wanted to make sure that we would see a benefit if there is one. And they were worried that, a single assessment at 15 days might have missed that because the study population was quite sick. So primary outcome is something important to look for in the study. And I encourage people to look up the protocol on clinicaltrials.gov. And you can just click tabular view and you can see right away the change history. Is the primary outcome, the current one, the same as the original, or is it different? So in this study, the primary outcome was changed, but that was done, they say in the paper, before there was any knowledge of the outcomes. And the change was something that was kind of trivial. And had they stuck with the original primary outcome, that still would have led to a significant result. So that's not a problem in my book.
Rahul, from this study, it looks like they have all those curves that nicely, the blue and red curves, and the overall curves separate, meaning, they found a significant difference between the groups. But the curves, when they looked at it for this kind of subgroup analysis, there was patients not requiring oxygen, patients requiring oxygen, then patients requiring like non-invasive ventilation, high flow, or ECMO invasive ventilation. So basically varying degrees of sickness. And when they looked at it that way, the patients who were hospitalized and requiring oxygen seemed like they gained the most benefit.
That's right. That is what they saw in, what figure is this? This is figure 2. I mean, anytime you see Kaplan-Meier curves like this with, overlapping confidence intervals, you have to ask that question, is there a subgroup that seemed to be driving the benefit here? And, there's a couple other things that you can assess about curves like this. I'll just say that in each case, it gets a little bit hard to tell for the subgroup of patients who were on high flow or non-invasive, and for the subgroup of patients who were intubated or on ECMO. But at least for patients not requiring oxygen and patients receiving supplemental O2, you can see that the patients who got remdesivir, the point estimates were always higher than placebo, and the confidence intervals are pretty wide. So I suspect that the reason that we saw this benefit in patients who were receiving oxygen was a result of the fact that that group simply had the most number of patients. All the other groups were smaller, so it suggests that patients who are hospitalized and requiring oxygen may be the driver of benefit. But unfortunately, with sicker patient populations, we can't really say whether or not they would also benefit because those groups were much smaller.
Right.
And Rahul, they mentioned having a lot of secondary outcomes. And which ones were you paying attention to and do you think were important to look at?
This was kind of an unusual case where we have this detailed paper trail about changing the primary outcome to a secondary outcome. So I was interested in the original primary outcome, and that was also a difference that reached statistical significance. There was also an estimate of mortality by 14 days, and I'll just highlight that this is still a preliminary report. We are expecting that the authors in the study group will publish the complete results once all patients reach day 28. But in this study, I was really interested in whether or not there was a mortality difference. It doesn't look like in the overall population there was a difference, 7.1% versus 11.9% between the remdesivir and the placebo group, respectively. We could get into a whole separate discussion about the p-value and what that means as far as our judgment of this difference. But my interpretation of this is that this was a secondary outcome. We did not see a mortality benefit of remdesivir in this trial. But taken in the context of the study as a whole, this is the first randomized control trial that suggests any benefit for a meaningful clinical outcome for this disease. And so for that reason alone, this is really exciting.
And Rahul, it sounds like we can't necessarily say it doesn't work for the sickest patients or those who were less sick at this time. We can just say overall for this group of patients, it seemed like the recovery time was quicker. And so remdesivir is potentially part of a treatment regimen going forward for COVID-19 if we think we have a patient that would have fit this study.
That's absolutely right. And, the authors do some subgroup analyses to try to tease that out a little bit better. They did stratify by patients who had symptoms for greater than 10 days and less than 10 days and found that both subgroups still had a benefit if they received remdesivir. So the way that the authors package all this is that you should really consider whether or not a patient who's hospitalized and requires oxygen can get started on remdesivir kind of as early as possible before they progress to intubation or requiring ECMO, because in this study, the greatest benefit was seen in those patients who required oxygen and were not more sick.
Yeah.
So overall, we have this study showing that the primary outcome, time to recovery, was statistically significant. Mortality was not statistically significant, but lower with remdesivir. So what is the future of doing randomized placebo-controlled trials with remdesivir?
That is a really important question. So how are we going to conduct studies in the future if we now have what could be considered a standard of care for this disease? Well, there's two ways to go about this. One is every trial of a novel therapeutic should be what's called an active controlled trial rather than a placebo control. So you test the hypothesis, is drug X superior to remdesivir, yes or no? And in a placebo-controlled trial, that question is just, is drug X superior to a placebo? That would be, in my opinion, the right way to do it. It's sort of less preferable way to study that question is what's called a non-inferiority trial. And I know people have seen these before. Non-inferiority trials are appropriate when there is an established standard of care and you're willing to accept a treatment that might be a little bit worse than the standard of care if there's other benefits, like it's cheaper, there's fewer side effects, we have more of it available. So a non-inferiority trial would be another alternative. But in my view, future studies going forward are probably going to be active controlled compared against remdesivir or non-inferiority.
And another big study to hit since our last episode was a triple combination study published in the Lancet. And this was looking at a combination of interferon beta, lopinavir, ritonavir, and ribavirin called combination therapy, compared to a therapy of just lopinavir, ritonavir. And there was no other placebo group. It was based in Hong Kong and open label randomized. And what they found was that they recruited 127 patients and they followed them with nasopharyngeal swabs and found that those in the combined treatment group had a shorter time to negative swab, 7 days, as compared to the control group, which again was lopinavir, ritonavir, which was 12 days to negative swab. And so they note in the abstract that early triple antiviral therapy, the combined therapy, was safe and superior to lopinavir, ritonavir alone. What do you think of that, Rahul? Lots of therapies going on, and we have PCR, but wondering about the clinical outcomes as well.
So as Emmy really nicely summarized, this study this is a great example, actually, of an active controlled trial, like we were just talking about, because the comparator group in this case was lopinavir ritonavir alone. There was no placebo. And as Emmy was saying, the primary outcome in this study was time to a negative nasopharyngeal swab. So a couple things that stood out to me reading and appraising this trial. The first thing I'll say is that this was funded by not the manufacturer of any of the component medications. That's an important thing to be aware of. This was done in Hong Kong, which I'll also point out is kind of unique among the countries of the world, really, in terms of how COVID-19 has played out. The pandemic came under really rapid control in Hong Kong because of their experience with the SARS outbreak in 2003. So people in Hong Kong, had kind of been through something like this before, and they had some sort of aggressive public health policies that kind of affect how we generalize these results. And the other thing that stuck out to me as far as the setup and design is who was included in this study. So all patients in the study were hospitalized with PCR-confirmed COVID-19. They all had to have been within 14 days of symptom onset. And they all had to have at least one vital sign abnormality. That's what is captured by this News 2 score, and you can look that up and see what it is on MD-Calc. They started everybody, consecutively enrolled patients on the treatment within 48 hours of admission, and they collected daily swabs for PCRs from multiple sites. A common theme we're seeing in these studies to try to get an understanding of the shedding of virus from multiple sites here. I think that's all that stuck out to me about the design. I would be happy to summarize some more of the results for you and take you through my appraisal.
Yeah, I just, what struck me about this, Rahul, Emmy, is like interferon and ribavirin. I thought that was like a very toxic treatment that we used to use for, what was it, Hep C, like before we had these other drugs. And, now we're giving it to like mildly sick patients with COVID-19.
So I had to do some Googling to fill in those knowledge gaps in my brain. Like, what were these drugs used for before this study? So people may remember from a previous show that we've done on lopinavir ritonavir, that is a protease inhibitor that was developed for HIV. And I think the most common adverse effects with lopinavir ritonavir tend to be GI upset. But it's a PO drug, so it's, a part of the regimen for some patients with HIV. Ribavirin was used as a part of a combination treatment for hepatitis C. And this basically is also a nucleotide analog, kind of like remdesivir, except this is a guanosine analog. And this one I actually don't really remember as far as side effects, if this one was, difficult to tolerate or not. This was also a PO drug, so this is something that, outpatients could get. And then interferon beta 1b. This was really like opening a dusty book in my brain back to the days of medical school. I had to relearn there are different kinds of interferon, okay? And beta 1b is a subcutaneous injection that is currently used for the treatment of MS. So outpatients, people who are kind of on maintenance regimens with MS, interferon beta 1b is often a part of that. And that's thought to work by increasing suppressor T cell activity and reducing pro-inflammatory cytokines.
Okay, so I'm misremembering, but these are definitely older therapies. It was interesting. I guess the whole idea behind the early drug trials is like we're trying to find something that's like already around that we can just repurpose, and that, I guess that's why they're trying to throw everything at this at COVID-19.
Correct. And I do seem to remember treatments for Hep C being horrible before the current era of curative drugs that we have.
And those were weeks, months of interferon. And this was, I think, 3 doses or so.
Yes.
Yes. So for those therapies, there was no placebo, but they compared it against lopinavir ritonavir, which the New England Journal paper showed wasn't effective. So why do you think that was?
It's a good question. The authors say in the text of the paper that the use of a placebo would generally not be considered acceptable in Chinese culture. And I don't have any particular expertise to be able to speak to that. And I also don't know if, there might be differences in Hong Kong compared to, cultural norms in mainland China. I have seen other placebo-controlled therapeutic trials done in China, but For the reason you're mentioning, Emmy, because we do have a recent negative study of lopinavir ritonavir, it may have kind of been effectively like giving people a placebo, because it doesn't seem like lopinavir ritonavir alone really reduces time to clinical improvement. So it might not actually be too bad of a thing to use that as an active control for this study.
Interesting. That's an interesting placebo choice.
So expensive placebo.
So Rahul, what was your read of the findings of this study? And is this a therapy that you think we should be using, or are they using it in Hong Kong?
Sure. So as Amy mentioned, the primary outcome in this study, time to negative nasopharyngeal swab PCR. Okay. And with any positive study where there was an association that was found between a treatment and an outcome, I usually start by looking at the protocol to see if the primary outcome was changed. And, this is something I would be interested in if they had chosen a clinical endpoint initially and changed it to a surrogate endpoint. That would kind of raise my alarm bells for raising the likelihood of a type 1 error or a false positive. So in the manuscript on clinicaltrials.gov, they describe how the study was powered to find a difference in something that was not the primary outcome. And I've talked to a few friends and colleagues about this. This is very unusual. This is not commonly done. If you're going to do a trial, you should make an educated guess about how many people you think you're going to need to see a difference in the outcome you care the most about. But the issue here was that because COVID-19 is a new disease, rapidly emerging, data are changing on a day-to-day basis, the authors had prior experience with SARS in 2003, and there was some uncontrolled studies at that time that suggested that patients who got lopinavir ritonavir with ribavirin had reduced mortality in comparison with historical controls who had SARS. So that was the basis for the authors choosing to power the study to look for a relatively large reduction in mortality or the development or ARDS at 21 days. So they thought they were going to see really sick patients coming into the door, like with SARS in 2003. But it turned out that the spectrum of disease with COVID-19 is much broader. There's many more mild and asymptomatic infections, so their study population was a lot less sick. Fortunately, they did not change the primary outcome. It was always time to a negative nasopharyngeal swab, and that remained the case throughout. So this was kind of an unusual decision, but in my view, it doesn't really affect my interpretation of the results.
And this kind of an outcome, as you pointed out in your tweetorial, this is like a surrogate outcome, and it's not necessarily like a patient-centered outcome. Like, I don't think patients necessarily care that much, other than being able to get out of the hospital, the negative swab. I don't think they would care about it. So I guess they're trying to just prove that this does something to the virus, but I always like when they choose a clinical endpoint rather than a surrogate.
Exactly. And so the question that we got to ask ourselves is there any utility in studying a surrogate outcome like this? We've already talked a lot about how detection of a positive PCR from a nasopharyngeal swab, we know that that's not a surrogate for shedding of infectious virus. But I have to believe that the converse or contrapositive, I forget the converse is true, where if you're not PCR positive, you're probably not shedding infectious virus. So if that means that these results could have implications for, efforts to reduce transmission. And I emailed the primary author with my question about the power calculations, because this seemed really weird to me. And, we kind of ended up having a long, nice email exchange. He's a really nice guy. And I asked about the use of interferon in Hong Kong. And after this study was published, it turns out that many hospitals and many centers in Hong Kong kind of adopted the use of interferon as standard of care for all patients with COVID-19. And whether or not, that could have had any role in decreasing the, occurrence of severe complications in Hong Kong, which we do know were less, fewer people required ICU care and fewer people died in Hong Kong relative to other places in the world. We don't know. There's a lot of other differences about Hong Kong that make it hard to generalize, but food for thought.
Yeah. Should we be giving everybody with mild disease like remdesivir and this interferon cocktail that they got in this one?
I'm waiting to see a study on a 6-drug cocktail, because why not?
Yeah.
Placebo of 3 drugs against it.
What else about this study and any final big conclusions that you took away from it?
Sure. I'll say that this population was not very sick. Only 15% of patients required any supplemental O2. Fewer than 5% required non-invasive at any point, and only 1 patient was intubated. And you may ask, why was this study population so well? Well, it's because in Hong Kong, there was a public health ordinance that required anybody who had a positive PCR for COVID-19 to be hospitalized. So that kind of affects our thinking about how to generalize these results to study populations where people are less sick. And, I usually don't make too much about secondary outcomes and subgroup analyses, but the authors did a subgroup analysis of patients who actually received interferon as part of the triple therapy, because they had a timeline cutoff where you could only receive interferon if you presented within 7 days of symptom onset. And the thought behind this was to try to avoid the pro-inflammatory side effect that can sometimes happen, maybe what was responsible for, Hep C treatment being so difficult to tolerate. Knowing that many patients with COVID-19 can start to get sicker in the second week, they wanted to avoid doing anything that could worsen that. So they did a secondary or a subgroup analysis where they looked at patients who did receive interferon, so the full deal triple therapy compared to just lopinavir or tenofovir. And it does seem like that was the group that really drove the benefit. They reduced the time to negative NP swab from 12.5 to 6.5 days. And this difference did not reach statistical significance among patients who didn't receive interferon.
I thought what was interesting about what you said here is, because we had speculated this on prior episodes, that they did treat these patients pretty early. And then the other really interesting thing is that this whole idea that maybe the interferon would have made people much sicker and contributed to this inflammatory cascade syndrome that we think makes people super sick. That's interesting that they were able to do that. I feel like what I've seen at CashLac and in practice right now, the patients that are getting, because these therapies are all still experimental, in clinical practice, most patients are not getting these drugs unless they're really, really sick, and then everyone throws the kitchen sink at them. But here they had the benefit of being able to treat them early, and they're bringing patients in before anything bad happens. So maybe that's something we need to aspire to.
It's a great observation. I mean, this study does raise the question, did triple therapy, including interferon, prevent clinical worsening in these patients who had relatively mild disease? At this point, we don't really know, but that is a testable hypothesis. So I'm going to be keeping my eyes peeled for further study in this area. So in my view, the bottom line from how I kind of appraise this study after putting it all together, this trial does provide evidence that among patients who were hospitalized with mild disease from COVID-19, triple therapy, including interferon, was associated with a reduced time to a negative NP swab. And it really did seem like this was driven by patients who received interferon or had their treatment started within 7 days of symptom onset. So we really do need further study in sicker patients and using clinical outcomes to know more about how this triple therapy should be used.
Emmy, so you're going to tell us why we should care, or what's the utility of these nasopharyngeal swabs? And I know you did a deep dive on that kind of testing. So what do you have to report?
Yeah, we see RT PCR everywhere, and it's I had to do a little refresh on what that is. So polymerase chain reaction, it's a way to detect RNA, and very small amounts, right? So we know that we have HIV tests undetectable as less than 15 per milliliter. That's so small. So what they're doing in the lab is they're amplifying, so that it's nucleic acid amplification techniques, and they amplify the amount of RNA using a certain DNA primer that we're looking for. So there's multiple primers that they use for SARS-CoV-2 that are very specific to its genome, like the spike protein or the nucleocapsid. And so they're able to amplify it over, up to 40 cycles so that you can detect it by a machine. And so this is a really good test in a lot of ways because it amplifies DNA, so it makes it very easy to see very small amounts. And thus it's overall very sensitive. And it's quite specific, right? Because it has to be that sequence of genome in the sample in order to turn positive. And this is different than, say, antigen testing, which isn't widely used, but there is one FDA emergency use antigen test on the market now, but most places are not using it because antigen testing is picking up big chunks, big proteins like the spike protein of the virus, and uses antibodies to detect that piece of virus. So back to the PCR testing. There's the manual tests, and there's a lot of what's called high throughput machines, which is basically like a easy bake oven. You have everything in a little cartridge or package, and then you can feed it into the machine, wait anywhere from 3 to 6 hours, and bam, you have a result. So there was recently a JWatch study comparing 5 of these high throughput machines, showing that their sensitivities are mostly all over 95%. And where they come into trouble is if the viral load is very low. If you have 100 copies, it may be missed. And the specificity for most of these is 100%, meaning when you're finding a positive PCR, that signifies that there is that RNA in the sample.
Isn't there a user error? If I think what you see people talking about, worrying about is, did they really get that deep nasopharyngeal swab and twist the thing like you're supposed to? Did they collect it correctly? Did the study address that? Are you saying if it's collected correctly, then the sensitivity and specificity are that good?
Exactly. Yeah. So it all depends on how are you actually collecting the specimen, and is there a specimen in the place you're collecting it? Yeah. So the trial I looked at was in the Annals of Internal Medicine, the variation in false negative rate in RT-PCR. And it was looking at a bunch of people that we know had SARS-CoV-2 infection and said, when did the PCR actually show up positive? And what is the rate that it was showing a false negative for an overall test of the patient? So it looked at 7 different studies and 1,330 test samples. And what they assumed is that they knew from all these samples when symptoms started or when the infection occurred. And they assumed that there was a 5-day incubation time and that the PCR, had 100% specificity. So if you took a sample from the patient 5 days prior to symptoms, which was presumed the day of infection, your false negative rate was 100%. Meaning the day we think everyone gets infected, they will not test positive, right? But then if you look to 4 days post-exposure, which they're assuming is 1 day prior to symptoms, your chance of testing negative is 67%. So that's a 67% false negative rate.
This is concerning.
Yeah. And then so, what about the day they had symptoms? So the median false negative rate on the day of symptoms was 38%. So the reverse is 62% of the positive patients were testing positive the day they had symptoms, and 38% were not. Again, this study had a pretty large confidence interval, so that false negative rate could have been 18 to 65%. But it makes you rethink, someone comes in with symptoms, you swab them and it's negative. Can you really trust that test?
Yeah, because Rahul, we just talked about, this had a very high sensitivity and specificity. And so very high sensitivity should mean that we shouldn't have all these false negatives, right?
I was worried you were going to ask me that because
I just don't understand what's happening.
So, well, you're not alone. I'll be honest, I'm not sure I fully do either. I mean, the observation that I have about this pooled analysis is that we often treat the truth of whether or not somebody has COVID-19 as kind of like a single moment in time. But I think this study really highlights how the test characteristics vary over time in relation to when a patient develops symptoms. So as we're talking, I'm getting a little lost in the weeds of the methods here, but that's my big takeaway from this is that, how confident we can be that a negative swab is a true negative swab really has to be, that judgment has to be made in the context of, does the patient have symptoms or not? And this suggests that, patients are more likely to be negative before symptom onset.
Yeah, that's challenging, because I think we'd all like it that if just someone has a negative swab, you just say, okay, that rules it out. But I think all of us I'm not that surprised. I was surprised by the first numbers Emmy was talking about, the high sensitivity specificity, because in practice, this kind of seems to be the behavior that we're seeing, where you'll get these patients that you think are going to be positive and they're not positive, and you don't believe it, and so you retest them, or you just treat them as if they have it, even if you weren't able to get a positive test from like an upper respiratory specimen.
That highlights the value of strategies like retesting, like for acid-fast bacilli, doing the 3 induced sputa to increase the sensitivity. I mean, in that case, there's probably not a substantial change from day to day in the amount of acid-fast bacilli that are expectorated. But in the case of SARS-CoV-2, it seems to be the case that the closer you get to having symptoms, the more virus you're going to be shedding and the more likely you're going to have a positive test. So it makes me wonder about if there's a role for retesting patients who you still have a high clinical suspicion.
And I will say, yeah. So the best time to test based on their analysis was 3 days after symptoms. So that whole week from symptom onset and that first week, you're going to get the highest yield. So 3 days after symptom onset, they were catching 80% of the infections.
And then the other part about this is this prolonged viral shedding. I know that's been reported for like up to 6 weeks after, which just, again, doesn't seem to go along with this like false negative thing. So I'm not sure what to do there. Did you read anything helpful about that?
Yeah, and it goes back kind of the CDC guidance where they say, wait 3 days after symptoms or 10 days after when it was diagnosed or started. And the reason they say that is there was a Nature paper, and it was only 9 patients, but it's hard to do these studies, where they found that throat swabs had no signs of replication after day 5, and sputum swabs had no signs of replication after day 10. So we think that after a certain amount of time, you still might have viral pieces in your system that can be picked up when amplified 40 times over, but it might not be multiplying. It probably isn't multiplying.
Rahul, we were talking about this before. Have you encountered the patient with the sort of phantom real-time PCR that's positive, and they had no symptoms or nothing to anchor it to?
I sure have. And, I think a lot of people who've been caring for patients with COVID-19, will have faced the dilemma of, well, when is somebody sort of safe to discharge home from the hospital? And in the Lancet triple therapy trial, they had a requirement where all patients had to have a negative nasopharyngeal swab times 2, 24 hours or greater apart. And I think before CDC had guidelines for this, there was a lot of variability in what people were doing around the country in the United States. But I think this is the basis along with a few other studies for CDC's guidance that in no patients with COVID-19 has replication competent virus been isolated any point after day 10 of symptom onset. So I've cared for patients who have been PCR positive for like 4 to 6 weeks. And, are those patients still infectious? Probably not so long after they've recovered from their symptoms.
And the last thing I'll say about this is there's been these whispers of reinfection. I'm still not convinced that reinfection occurs, and most experts, I'll talk about it a little bit with the serology, most people think that you do gain some protection when you develop antibodies and you get an infection to this. And the Korean CDC had some patients that they seemed to have a negative PCR test that then became positive again, but then they traced those people out and they didn't seem like they were infecting anybody, so they are not really doing anything about those patients. And this all goes along with this, that we might detect viral material for a long time, but we don't think it's infectious.
And you have to be very impressed with how well South Korea is doing contact tracing. Oh my gosh.
I know. It's great. We need some of that here. So serology, what's out there? There was a great paper by Teal that was in the Journal of Clinical Microbiology at the end of April. And this paper, this was a group, they were talking about the various antibody tests that are out there. So there's a lot of variation and they're not that heavily regulated. The FDA is basically like, just, tell us what you're doing, but they don't really need to get emergency use authorization. It's not required. So there's IgA, IgM, and IgG, but the IgG is what most people think is going to be most useful because it's longer lasting and it may be associated with neutralizing antibodies, which we talked last time. Neutralizing antibodies are what can potentially prevent the virus from entering cells and offer protection. So the ways we might use these antibody tests in clinical practice, one is to identify like people that have already been infected that might be able to donate plasma, by checking their titers. We can look for do seroprevalence studies and try to figure out like what percentage of the population has antibodies and has been exposed. And then another possible is monitoring the response to the vaccination. So if someone's been vaccinated, like we are going to want to know, like, the way you get the hepatitis B vaccine series, and sometimes they'll check your titers. So the article that I wanted to present is by Brian et al. And this was not an industry funded study, but it was looking at the abate SARS-CoV-2 IgG antibody study and antibody test, which looks at the nucleocapsid protein. And it seems like this test is very sensitive and specific, with the caveat that you have to wait a certain time after PCR positivity or after symptom onset. And so at 13 days after their PCR is positive, this is like 100% specific, sensitive and specific. And at 17 days after symptoms, it's 100% sensitive and specific. And as you get closer to the symptoms or closer to the PCR test, the performance isn't as good. Rahul, anything to say about this test so far?
Well, I'm definitely not a content expert in, knowing how antibody tests should be used, but, just kind of going off of the kinds of questions that we have about who has COVID-19 and who doesn't, it seems like the relevant things that you'd want to know are, number one, do antibodies confer protection and for how long? And number two, what proportion of the population has already been exposed to a disease? And there was a lot of buzz in the lay press about some of the serosurvey studies that were done in many places in the country, but notably in California. And the only point I would make about that is that the test characteristics of the test really do matter when you're trying to estimate, what proportion of the population has been exposed. A specificity of 96%, sounds really good, but if the prevalence of disease is low, then you could easily end up in a situation where you have more false positives than true positives. So the thing I would advise people to think about when you're reading studies about the test characteristics of antibody tests, in addition to what are we testing for and what is the clinical utility, think about the test characteristics, because that can really affect your estimates of prevalence quite a lot.
In this study by Brian et al., in Boise, they tested about 4,800 people, and they found that the seroprevalence there was like 1.8%, but the patients kind of had to volunteer. It's probably not the most ideal way to test. It wasn't like a random sample. It was just people that volunteered. So probably people that thought were very curious about if they had antibodies or not. And the other thing they did do, which I thought was reassuring, and that's I think is important, is they looked at 1,000 samples that had been done, that had been taken, and they were from the University of Washington. And these are samples from like before COVID-19 was around. And in those 1,000 samples, there was only one false positive. So one of those tests met the threshold that would have been called a positive test. And so that gave them like a 99.9% specificity based on that.
That's really encouraging. That's pretty good. Only one
Yes.
false positive is quite impressive. And chances are that was, a patient who was infected with one of the endemic coronaviruses and, got unlucky and had some cross-reactivity. But that is a suitably high specificity.
And so far they have looked at the other coronaviruses, and there's only like the amino acid sequence has only about a 30% homology, whatever that means, between SARS-CoV-2 and the 4 circulating coronaviruses. And what is reassuring about these 1,000 patients is that in patients over 50 years old, it's very common. Like almost 90% of people have antibodies to the common coronaviruses. So the fact that this sample of 1,000 patients, didn't have a lot of false positives, things are suggesting this test at least isn't going to cross-react. And what I would leave people with is, if you find out which test you have, try to find out the test characteristics, and then you have to think about how prevalent is the disease in your community. Because if it's low prevalence, and then you're going to have more false positives.
I couldn't have said it better myself.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. Yummy. Get show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledgefood to get our weekly show notes in your inbox.
I think that was the first time the person reading that first part actually said yummy. So we're committed to providing you with high-value, practice-changing knowledge. To do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecurbsiders@gmail.com. A special thanks to our producer for this episode, Deb Gorth, and a special thanks to our social media team, Hannah R. Abrams, still kind of on Twitter, Beth Garbs Garbatelli, now on Twitter/Instagram. Welcome to Maddie Morgan, and we'll think of a nickname. And thanks to Chris the Chew Man Chew for doing our Facebook. Until next time, I've been Dr. Matthew Frank Watto.
I've been Rahul Ganatra.
I've been Emmy Elizabeth Okamoto.
And this has been Sarah Feedy Roberts. Thank you and good night.
And thanks to our partner, VCU Health Continuing Education, who's helping us offer free CE credits for physicians and other healthcare professionals. Check out curbsiders.vcuhealth.org for more information.